Okay, so welcome to everybody who's joined us for our Hidden Disabilities Ask an Expert webinar today. We're going to be talking about prescriptions and medications and some of the difficulties that people are facing, accessing these, understanding these. And we have got a panel with us. We've got Dr. Sanjay Gupta, we've got Jaya Authunuri. I might have pronounced that incorrectly, I'm not sure. We've got Dr. Dinesh and Dr. Rashid. We have got some specialists and some suppliers. We've got Chantel from Thomas Medical Services who does IV saline. And we have some of our service users, our members basically from our Hidden Disability charity community. And they are here with their lived experience to say about the difficulties and ask the questions. And Sanjay has invited some of his community today as well, so we can all get connected. So because there's quite a lot of us, I obviously know our members and I know some of the questions they want to ask. So I can go across and we can give them the opportunity to ask their questions direct. The rest of you, if you could put your questions in the chat box and I can keep my eye on that, it just speeds up the process because there's quite a lot of you. I also have some questions that have been emailed across to me as well. So we'll try and answer as many things as we possibly can. So just to tell you a little bit about the charity and why we are doing this. I'm the founder of the charity. We've just started our second year. I started it because my daughter has a chronic condition. She's actually got POTS, which is how I know Dr. Gupta. It took 7 years for us to get a diagnosis. The medication, the support, the lack of awareness in the community, and a huge host of other problems for this group became very evident to me. So I set this up to try and make a change and impact and try and gather people together, because I do believe the more people you speak to, the more you have a better understanding of the whole problem, and people are very isolated and it's very fragmented. One of the great things with having Hidden Disabilities charities, it isn't a specific condition we are dealing with. So lots of conditions merge, there will be people with more than one condition. In fact, most people have more than one condition. So it means we can deal with everybody with all the different problems going on there, and we get a full picture. We get a bigger full picture of what the problem is, which puts us in a good position to gather the information and share that. So the charity is we are completely non-biased. We're not political. We don't have any ulterior motives of anything, so we can totally remain impartial. And although we can't recommend things and have opinions, we can definitely create conversations and we can gather everybody together, so that what we are sharing is just it's just direct information, and then you make up your own minds about it, because we are not trying to sell you anything. We are not, we have not got we haven't got any agenda. So you can gain information from us, which we will gather from the doctors, from suppliers, from patients, and we will share that and we will create open conversations like what we're doing today. So that is the idea behind this. Because we're recording it, we can then send it out, and we will put these recordings on our website, and Dr. Gupta and other people will be sharing the recordings as well. We did one on IV saline in October, which was really great. That is on the website at the moment. We've got we're wanting to do one a month on different topics. So that's kind of what we're doing. If you're interested in finding out more about the charity, our website is hiddendisabilities.org.uk, and we have got a welcome event on Wednesday, which is a big welcome event, which is open to anybody. That's in Hull at the Doubletree. I do appreciate some of you will not be in our area, which is why we're going to do some things virtually as well. and we'll put more resources on the website too. So it's early days. As I say, we're only in our second year. So let's get cracking then. So as I say, today we're talking about prescriptions and medications. So I'm going to start with Dr. Gupta, because he was telling me about some difficulties that that POTS patients are now getting. We're not just talking about POTS today, we're talking about other conditions too. Yeah, we'll start with him and he will give you a bit of an overview as to some of the complications of what's happening in that sector. Take it away, Dr. Gupta.
Well, thank you so much for inviting me. I think this is an incredible initiative, and I'm so happy that there are people from all over the world who are joining today. The first thing I would say is that I think it's very important for us to realize that as doctors, we should treat patients. We don't treat conditions. We should treat patients. We don't treat test results. We should treat patients. We don't treat numbers. We should treat patients. And therefore, one of the big problems we face is that as a profession, we are so guideline based. We are such slaves to evidence that we never want to venture out of our comfort zones. And so when people start complaining or presenting with symptoms that don't make sense to us, it is easier to make them sound like they're mad rather than keeping an open mind and an open heart and trying to listen to them to try and make sense of it. And when we do those things, we start realizing that lots and lots of patients are going through the same journeys. Those journeys are never recognized because we never give them the chance. So I'm very fortunate that over a number of years, I've started getting to know people. I've started being more empathic and just listening to their stories. And a lot of my experience with this condition doesn't come because I'm some kind of world authority or I've done anything. I'm just someone who enjoys communicating with patients and listening to their stories. And at the end of the day, whatever the patient describes, it is not for me to judge whether that is valid or invalid or deserving or not deserving. I am here to help. That's all I can do. Sometimes just listening helps. Sometimes doing something helps. And by far and away, when one steps out of their comfort zone to try and help patients, it is incredibly enriching for the doctor as well. That is the most enriching part of my professional life. And in this particular condition, dysautonomia, dysautonomia is a better term than POTS, because POTS is a very restrictive definition where you imply that the condition is only one which is to do with standing up. You start realizing that virtually all patients say that this is not just something that bothers me when I stand up. This bothers me all the time. Yes, I feel worse when I stand up, but even when I'm lying down, my life is rubbish. I get all these other symptoms of incredible fatigue, brain fog, temperature dysregulation, gut issues, headaches, etc., etc. So then you start realizing how limited we are, how limited these definitions are. These definitions aren't capturing the patients. These definitions are man-made definitions, and they are not cast in stone. We can open things up. We can change definitions if we wanted to, but we have to first start recognizing that these patients deserve our help, whatever it is. Whatever it is, it doesn't matter what to me. It shouldn't matter to me whether it's whether it's mental or it's environmental or physical. I'm here to help. Full stop. It ends there. That conversation ends there. You do not have to deserve my interest. You get it as default because that's how I've set myself up, and that's how doctors should be looking at patients. Now, when you face these patients, then you cannot help but become invested in their stories and start realizing actually how much hardship a lot of patients go through. Most of the patients I have met are incredibly intelligent. They're incredibly warm. They're incredibly open. They want to try anything they can to make themselves feel better. And what I started realizing is that there was very little available to help them because everyone would rely on evidence. And where is the evidence going to come from if no one even believes that these are conditions? that these are deserving of anyone's interest. So over a period of time, I thought, okay, well, if you don't have experience, you won't get evidence. So let's develop some experience. So what I started doing is I started finding out from small studies, which were not considered big enough to be considered evidence, that there were certain medications that seemed to help. There's no doubt that medications only form a small part of the overall management, education, empathy, empowerment, lifestyle modification, physiotherapy. But despite all this, patients really, really struggle and they have a very suboptimal quality of life. So I thought to myself, okay, let's try some medications. And we started developing experience in different medications. Again, none of these medications are in the kind of guidelines. And because they're not in the guidelines, there is a lot of, uh, you know, obstruction. Other doctors seem to think, okay, well, why are you using this? So they all have this kind of, they're used off license. They don't have a license for this particular set of conditions, but I've started using them. And when we did use them, we found that a proportion of patients came back and said, oh my God, that's made me better and not worse. And that's all we want to do. So over a period of time, I've started using a bunch of different medications, and I'm always amenable to trying more because that's how you build your experience, and that's where the evidence base will come from. So we use the simple way to try and think of medications is what you want to do is for a lot of patients, the heart rate going fast is a problem. And therefore, we try and control the heart rate. And there are medications that you can use to control the heart rate, arguably beta blockers, but also another medication called ivabradine. And ivabradine works generally very well. I would say 70% of my patients will come back and say, I'm pleasantly surprised that this has done me some good. So we started using ivabradine. And then a lot of these patients will also actually run a low blood pressure because generally they're otherwise physically healthy people. It's not that there's a structural problem, it's more a dysfunction of the autonomic system. And we use medications like midodrine. Another medication we use a lot of is uh, pyridostigmine, which is a rest and digest enhancer because patients with dysautonomia are always wired and tired. They always have too much adrenaline on board and too little rest and digest. That's why they complain of this terrible tiredness, bloating, constipation, that kind of thing. We use a medication called low-dose naltrexone, a gentle anti-inflammatory, which helps with fatigue, post-exertional malaise. And one other therapy that I've come across, which makes a tremendous difference, albeit only temporarily, is intravenous saline. IV saline seems to work really well for people, but those benefits last a couple of days. But what I have found is that when you take a person who is bedbound for 7 days a week and you can give them 2 days where they can do a little bit more, where they can get glimpses of the identity that they've lost, that in itself is very empowering for patients. So those are the things that we use. The problem now is that certainly in York, the other doctors turned around and said, well, these are not licensed medications. We're not going to prescribe them. And so a lot of these patients were unable to then access these medications on the NHS because the GPs were turning around and saying, we're not going to continue prescribing them. They stop now. We're in the midst of this collective action thing. It's too much work. We're not going to support this. So subsequently, I had a problem because a lot of my patients would say, well, then you prescribe them on the NHS. But obviously, if we have 3,000 patients, then it's very difficult for one person to continue prescribing these medications every month. So these were the kind of problems we had. Fortunately, Jaya Authunuri is in the room and he stepped in when we had this dilemma. And I said, look, Jaya, how do these poor patients who were benefiting from these medications, who are now being deprived of these medications, even though they have been on the medications for 2 years, 3 years, there's been a noticeable benefit in their symptoms. When they stop the medications, they get much worse. But because of their illness, they can't work. So they can't afford these medications privately. How do you go about resolving this? And Jaya came in and he said, look, I will make sure that these medications are available at much more affordable prices, even privately, for those patients who can't access them on the NHS. At
So,
that point,
Dr. Gupta, shall we bring in Jaya now?
please.
It's a good little introduction to him, and we'll come back to you shortly. Jaya, if you want to unmute yourself and just introduce yourself and tell us a little bit about what you're doing. And I know you come into the welcome event on Wednesday, and I've asked you to get like a price structure available for people. Yeah, do you just want to tell us a little bit about what it is you're trying to do?
Thank you, Natalie. Thanks for having me here. And thank you, Dr. Gupta, for introducing me to the wonderful community of POTS and people from hidden disabilities, because I've learned it through patient testimonials than anything else. Although being a professional and being working in the profession for a while, I wasn't aware of the condition until a few months ago. That's when I came to the charity ball, I've heard from the patients' testimonials as to what a life changing condition this is, and how managing these conditions going forward is making such a difference to everyone. And my role specifically, being a pharmacist, not, yes, yeah, supplying drugs is not so exciting, just sticking a label and giving it out to the patient. So when Dr. Gupta did tell me about the difficulties of accessing these medications on the NHS, and I do work in the NHS, like Dr. Gupta, and I know the red tape that we have when we prescribe these medicines. There are layers of people that are employed in the NHS under the title medicines management teams that purely look at what your GPs are prescribing, and go around to tell them off if they're not prescribing as per the guidelines. Hence, these doctors are a bit, GPs are a bit worried in terms of prescribing something that is outside the box, or outside the licensed indication, etc. Just so that they can't be bothered having hassle from the commissioners, we call it, above. So just to bring it into context as to why can't my GP prescribe this, is if it's not listed in the local formulary under a certain condition, then it's a clear no. They would be just going by what these protocols and the guidelines say in their local formulary, and they'll prescribe it
Oh la
accordingly.
Madonna, basta, Marco, ti intrippanci.
Hang on, can you
So
just make sure you're muted,
so
please?
that's okay. That's where I thought, yes, these medicines can be expensive if you're going to different pharmacies and whatnot. So I kind of put a price structure which is very transparent to Dr. Gupta's patients, and said, here it is. There might be a little bit fluctuation based on varying market conditions, because if medicines are globally manufactured, very little gets manufactured in UK, and based on the availability of raw materials, etc. The price sometimes varies, but I kind of fixed it to see how it goes to begin with. And I think I'll welcome the feedback from the users here, from the charity, and how they're finding, etc. I've also noted some questions as I was going along when Dr. Gupta was giving the introduction. I thought when we start the discussion, Natalie, I made some points and notes around how do we go about these things. But any questions from the audience here, I'm more than happy to answer.
Yeah,
Thank you.
well, we'll go through some of the questions as we go on. So one of the problems that we was talking about at the IV saline event that we did was accessing certain medications, because some people are supplying it to only one area, and then they're monopolizing the pricing structure, and we was talking about that. Can you explain that to the community as well, please?
Sure. I think in particular we were talking about low-dose naltrexone, which I think Dr. Gupta brought it to my attention around it being available through a private consultation of £50 through a particular chemist, and then subsequently, I guess, the charge on the medicine itself. So I thought let me try and source it. So we are able to now source low-dose naltrexone. Now I have to sit down and work out what the pricing structure is for Dr. Gupta's clients and whatnot, but it's going to be affordable. There is not going to be any consultation fees or whatnot in advance for this medicines. I think there was a £50 consultation fee. So we're trying to make these medicines more accessible with less charges that are surrounded that particular prescriptions, etc. So yeah, I managed to find some success to that, and hopefully we're going to advertise it to the audience once I completely get the pricing structure correct.
Yeah, but there was some things that was really almost that run out of, you know, you were saying now you can't get hold of these, you know, and what was that you was telling me about?
So even today, I had the conversation with Dr. Gupta was for a patient that needed urgent medicine posted. We had 4 out of 5 desmopressins out of stock at the moment with all the wholesalers, the nasal spray. So unfortunately, the current climate where we are, the NHS negotiates very hard for the price of drugs, either for the NHS or private market. And these drugs are manufactured globally, so they look at markets where they get better prices. And they get shipped away that side. And I think we kind of fall slightly on the bottom of their priority list in terms of the supply chain. Let's put it this way. Although no one will admit it, that's sort of the fact. And sometimes these medicines are prone to go out of stock. So I kind of told my procurement team today to say that if it is available, just order in bulk so that we do have a consistent supply as patients are needing, rather than ordering it sort of for the prescription sake and whatnot. Because as you know, I can understand without these medicines sometimes I know how things can be quite bad.
I think Dr. Hazim has got a question. I'm just going to ask him. You don't have to unmute, but I'll just get him to. And I've got more people coming in as well. Dr. Hazim, do you want to ask your question?
Hear me?
You're quite quiet. And we can't see you. Oh, there you are. There you are. We can see you. But we're going to see the top of your head. There you go.
Hear me? Hear me?
Put your screen down a little bit. There you go.
Perfect.
Hi.
Can you hear me okay?
Yes, we can hear you.
Hi, good morning, everyone. What a great turnout. Thanks, Natalie, for inviting me. It's always been a pleasure to be in such a group.
Just put your screen down. We can only see half your face.
Can you see me now?
That's it. Yes, we can see you. Thank you.
So I'm going to talk about POTS in a different perspective. I'm not sorry, I didn't want to interrupt Jaya. I'm on call, so I just wanted to say a few things about
a webinar about POTS that's live.
Sorry, can you mute?
About
somebody.
I'm just muting people because yeah, we have to keep everybody muted while the speakers are talking. Thank you.
So I'm going back to Dr. Gupta's point about the limitations and our restrictions. I was just taking some points down. I think it's time that I've been saying this for ages and ages, naturally, I'm sure to you and other people, that we have to raise the awareness from a different angle. I think clearly the message is not going out. I'm just suggesting, now that we're building up such a huge community of POTS, is it time that we create our own stuff in a way? I know it's out of norm, like in a separate guidance in a way. So approaching the really decision makers, I know you have to work under the NHS umbrella, but not necessarily. There are few services I know, they've done tremendous work by lobbying directly with local, because public has got a huge power. I've seen that in many hospitals and services. Public has a huge say on any government decision. So I know an MP who's elected just on the basis of a care services in a certain area, and I'm sure you heard about Bidlington, where basically an MP got nominated 6 years in a row just because they wanted to keep the hospital going, because they wanted to shut that hospital 6 years ago. So I think public has got a lot to say. So why don't we now, I know we do a lot of talking and helping and raising awareness, but we just have to hit the core of it. And I think that is the key, so that we can do the decision making ourselves, rather than actually relying on all this, just on the awareness. I don't know, I'm talking out of the book, but I think it's quite time, because we see POTS patients suffering every day, every week, and that's just can't be just with a committee and meetings like this. I think we just have to hit the core. I just want to say that strongly. I don't know where else to say this, but I know NHS leaders will listen to us if we do that in a different angle. And just a simple thought. In regards to medication, I'm sure Jaya is doing a great job with stuff, but my own practice, I'm finding patients can't get medication from the GPs, they can't get medication from the hospital, because our service has been stopped by my hospital, my service has been brutally stopped by the management, and I'm very, very vocal about it. And again, they're looking at the evidence, and so I think whoever is looking at the evidence, they never consider anything else. So that's why, going back to my first point, that we should be hitting the core. Who's making this decision? Why can't we have our own community of POTS patient and the doctors who knows what to do with the POTS patient? People who has got no knowledge, little knowledge is a dangerous thing, as you all know. So because they don't have any knowledge about it, they just basically don't actually know what to do with them, and give false hope or false decision making made. So I think it's time we do that in a bit more stronger version. I mean, a much stronger way, rather than just creating awareness. Thank you.
Okay. Good point, and very interesting. Is there any of our hidden disability members there who would like to comment on that? And I think Sanjay would probably like to comment on that as well, would you? So just if you're a service user, if you put your hand up, I will be able to see you, and I'll just go to Sanjay and see what his response is.
I think the first thing to say is thank you. I think the first thing to say is that, we're obsessed with numbers, and we're obsessed with sort of things which are dangerous. If it's not life-threatening, it's not important. But I think quality of life is really, really important. And when you see the quality of life of young people, people in their teenage years being destroyed because of a condition, they miss out on some of the most formative years of their lives because they feel so miserable. They can't make the social contacts, they can't go to school, etc. That is a travesty, and that should be considered a travesty for any government anywhere. The problem is that I personally think it is very difficult to change the system. The system is the system. And I think it's very difficult to accrue evidence about quality of life, because quality of life is such a subjective thing. Everyone has their own identity, they have their own aspirations, they have the quality of life can only be measured by the person whose quality of life it is. It can't be, any kind of measure like that. If I say this is what quality of life should be, that's wrong. You are all entitled to the life that you want to lead. And therefore, it's always going to be a little bit more difficult accruing evidence. But the nice thing is that you don't need any more evidence. You just need the person whose quality of life it is to come to you and say, whatever you did, you've made a beneficial difference. And that is enough. And therefore, personally, I feel that as Dr. Hussain has said, I think rather than spending too much energy and too much time changing the system, what we should be doing is empowering patients and making facilities available locally that those patients can tap into. Now, the intravenous saline thing is incredibly interesting, because I had about 7 or 8 patients who had terrible lives, terrible quality of lives. They were bedbound, they had small children, they couldn't look after them. One lady had never been able to celebrate her child's birthday because she couldn't stand up to host a party. So these people came along, and because there was nothing else I could do for them, I thought, out of desperation, let's give them intravenous saline. And lo and behold, many of them thought that was transformative. They said, look, I feel okay now. I feel great. I feel fine. Please don't stop my saline. All we would get is compliments, thank you letters. 3 years down the line, a rheumatologist who has no concept of POTS, who has no interest in it, turned around and said, this is not evidence-based, stop it. There is no evidence base. The 7 people became so miserable, they went back in their wheelchairs, they launched a petition, they said, look, this was life-saving, this was so important for us, and it's been taken away. No one budged, no one budged. But the question then is, how do you access this treatment that has made a difference to these 7 people? So I went to our managers and I said, look, these people are so much better as a consequence, and therefore I think you should keep it available. You should make it available to them again. And they said, well, 7 people doesn't count as evidence. I said, I'm not asking you to give it to another 100 people. I'm just asking you to give it to those 7 people who say their lives change as a result of it, and they still wouldn't budge. So finally, through a charity like yours, I expressed my frustration at this, and Chantel Thomas came along and she said, okay, I will provide this service. And suddenly now we have a walk-in clinic where those people who benefit from their saline can just go, not be treated like they're a drain of resources, not be treated with suspicion and almost discussed by some of the nurses and people like that who don't understand the condition, but actually go in, have their saline. And I'm so glad. And so these are the small things that we are doing without having to lobby governments or making changes. Let the ignorant continue, and let us all get together in an environment which fosters empathy and make things available at affordable prices for the population to tap into.
Yeah, so thank you, Dr. Hussain, for raising that point. I think it's a good one. I think as our community builds, we will gather momentum, and we will be able to address and look at some alternatives. We do need to get the feedback from the service users to let us, know what it is that would help them. And the IV saline, we as I say, we spoke about that our last webinar, and you can see that on the Hidden Disabilities website. But my daughter's been having that too, and it has been transformative. And I know lots of people in our community have been trying that. So we'll put Chantal on in a moment, and she can tell you a little bit about the service that she provides. This is something that when we was discussing it at the meeting, Dr. Dinesh said, well, I know doctor who's got a venue that you could potentially use, and everybody who's kind of networking and problem solving at the time. And Chantal was like, well, I've got the service, and she's having to travel, I need a venue. And everybody sort of pulled together, and now we have that service available in Hull, which is amazing. And that's how we can all pull together and really do make a difference. I've got Miriam has put a hand up. Did you want to let me take you off?
Sorry, just a quick
Miriam.
Hi. So 10 years down the road, my daughter's 25, and she has a combination of issues that were actually all triggered by a genetic mast cell, but dysautonomia was what was picked up. We have access to saline. I've just learned over the 10 years that actually, if you manage to get something, I really care about being part of the solution for others. But the problem is, the moment you open your mouth, management now are aware that we have access to stuff because decent doctors have provided it. So I think it's a really fine line if we're trying to galvanize us as patients to be part of the solution, but also to be canny. Like in Hull, you've come together and you've made this happen. There are situations where people innocently will say something, not knowing that actually that's going straight back to somebody who can put it in a block. So for me, a word of caution, desperately want to be part of the solution. And also I want to protect. It means the world to sit here and see these doctors' services. A pharmacist, never saw a pharmacist who talked pots before, and hello in Thomas Medical Services. You've no idea what it means, but I feel really protective. So yeah, I just wanted to throw that out because I know previously I've gone, oh my goodness, there's all these people who really care. And then you watch them getting shut down. Thank you.
Thank you for sharing that. Whereabouts are you from, by the way? You obviously got a Scottish
So
accent.
I'm from Ireland originally, but I live in North Scotland. No, I live in Northeast Scotland. So yeah, I'm pretty familiar with the Scottish system, and there's nowhere in management they want dysautonomia. Nowhere. We've done lots of political things, and we'll keep doing them. but the NHS know they can't afford it. Same with Marcel, so they're not going there. Thank you.
Thank you. Great points. Thank you for sharing. Do you want to, actually, Chantal, let's introduce you now. I'll take you off mute. Do you want to tell us about the IV saline service that you provide and some of the impact you've seen from the patients?
Absolutely. So hello everyone. Thank you so much, Natalie, for inviting me to this webinar today. It's so beneficial to get everybody together. So, you know, you've got the clients, you've got the doctors, you've got everybody's kind of perspective. So we offer IV saline around the UK. We've got 2 locations currently. Thankfully, we've now just launched our Beverley clinic, which is at Beverley and Molescroft Surgery, and we are there every single weekend. And that's going really well, so thank you all for making that success. And we've also got a full-time clinic here in Blackpool, which is where I am now. IV saline, where do I even start? So it quite literally is magic in a bag for the patients with POTS. For example, when we discussed the IV saline webinar last time we did one, I explained how we look after a young girl here at the Blackpool clinic who actually arrives in a wheelchair and she leaves walking. And if that doesn't go to show how powerful IV saline is, I don't know what does. I'd probably say that I've got a very special bond with each and every single one of our patients here at TMS. And that is because my mother has POTS and fibromyalgia. So I understand the struggles and, you know, the power that IV saline and people such as everybody in this webinar today can have on these individuals and their mental health alongside their physical health, which is just as important. So the way, I don't know whether there's anybody in this webinar that's been to us before, but the way that we operate is very relaxed. We want it to be home away from home, the way you're getting treatment. Our Beverley clinic, obviously being new, we're still hitting bumps in the road, so we are obviously getting there, but we want to make it more of a community aspect. So you'll often find that when you come to your IV, you'll be sat chatting to us, you'll be sat there with a cup of tea and it'll be super relaxed. We don't want it to feel such as a medical environment, if you will. But yeah, the powers of it are quite unbelievable. If you are unfamiliar with IV saline and never heard of it or don't know how it works, etc., essentially it tricks the body into thinking it has a higher blood volume, which can eradicate or basically die down the symptoms of POTS altogether. We often find, for those who don't know, that it can last up to a week. However, everybody is different. Some of our patients come to us if they have a big event on, like a wedding, something like that. They want to be more, you know, able to do the things that once they were able to do. But, you know, questions away in the box and we are happy to answer all of them. But thank you so much again, especially to Dr. Gupta and Dr. Dinesh and Jaya, who is our now new pharmacist and prescriber. Which actually brings me on to say, so I wanted to wait until this webinar to announce this, but we've actually, after joining with Jaya, we've actually been able to decrease our prices even further for IV saline, which is something me and Natalie have been trying to do for a very long time, because it's not genuinely about financials for us. It's about helping patients with POTS, with having such a close relationship to it with my mum. And, you know, building that bond with you all. So, yeah, we have lower prices now, which will be launched on the website.
Fantastic news, fantastic news. So we do have one of our members who has been to. So I'm gonna put Susan on because Ellie's been coming and having the treatment, hasn't she? So can you unmute yourself, Susan, and just tell us what Ellie's, I know Ellie's not available today, but maybe you can tell us about her experience and the impact it's making on her.
Thanks for that, Natalie.
You're welcome.
I was being very quiet. So Ellie's struggled. We've had the saline before through Dr. Gupta, and it's amazing. She recently had her last lot. she's now got this visible armband that records her health and heart, blood and pressure and everything. After the saline, she was a stability of 5. Normally, she's a 1. So anybody that tells me it doesn't work is a liar, because it is just amazing stuff, a bag of saline. Although Chantel doesn't like us coming very often because she can't find a vein.
So what does she do to help? Because I know Ellie has real difficulty with injections and things, and a lot of our POTS members have, and it really puts them off going for the treatment. So what has Chantel done to help with that? I was asking you, Susan.
Can you hear me, Natalie?
Yeah, can now, yeah. I'm just putting somebody on mute.
Okay.
Yeah, if you just, everybody else, if you just remember to keep yours on mute so it doesn't interrupt.
Are we back?
You back.
So Ellie has very, very hard veins to find, as Chantal knows. Was very worried, and it's always been a concern to me that eventually we're going to struggle with these veins. But Chantal never gave up. She always finds a solution. If at any point there is no vein, she would give us the injections for Ellie, which is just massive. Absolutely massive, because we thought we were going to go, no vein, go home. And that's it, we are done. Chantal never said that. She never gave up. And then she's introduced a new lady, Maggie, who is amazing. And she found a vein the second attempt. So there's hope, more hope. Ellie's happy. They look after her, they spoil her, they distract her. They're just an amazing team to be having. So this is accessible. So Ellie's going monthly at the moment, but after that Chantal's announcement, we will probably be going weekly, which will be just fantastic. Ellie, the next day when Ellie has the saline, she's tired. The day after, she is a different person completely. Confident, happy. She is not moping. She's not saying, this is it, I've had enough, I don't want to be like this. She's just amazing.
Yeah, I mean, I've seen it's transformative, and like with Bethany, my daughter, she's tired the day she has it, but for her it has lasted all week, and she's now planning things in. She has got a much higher standard of life, a much better life quality since doing it. So let's put Chantel back on again, and let's find out how much what she's charging. And I've got some other questions that people are asking, which we can just cover as well. Thank you very much, Susan.
Thank you so much, Susan. And I just wanted to say, Susan, those sausage rolls were beautiful. Thank you. So I just wanted to come on and just slightly reverse back to what Susan said about difficult veins. So obviously all of you would probably agree, or the majority of you would agree, that people with POTS are difficult to cannulate or gain access at all. And that's obviously due to the dehydration and the lack of blood volume. So here at TMS, we hire nothing but the best, essentially. So we have Maggie, who would be our new phlebotomist down in Beverley. So if you're in that location, that's who you'll be seeing. She has done 27 years in chemotherapy at a cancer ward. So 9 times out of 10, she will find a vein. And we've also got Harrison, who works at AMU at a hospital, so can gain access in emergencies and is incredible. And obviously, you've also got myself. Now, to reassure you all, it's completely normal for whoever you go to for your IV saline to potentially miss a vein. I want you to know that that is normal. It can happen. Veins can collapse, etc. But here at TMS, we won't give up, and we'll always find an alternative. And that's why we've got what I would deem as one of the best phlebotomists down in Beverley. And she was very difficult to find. So I'm glad that you like her. She fits the criteria very well. So yeah, she's incredible. She's really great. So touching on Natalie, you asked a question regarding the IV saline. Could I just ask you what that was again?
Well, I've got a few questions that are coming in, right? So let's go through them, right? So one is saying, where in London can I get this service?
So leave it with us. I am not aware of anywhere in London affordable that you can go. London, due to some of our clients letting us know, I'll just say it, is renowned for costing a ridiculous amount for IV saline. However, what I want to reassure everybody is that we are trying to find we mentioned it in the last webinar that we did, but we are trying to find nationwide phlebotomists who can potentially come and host pop-up clinics and or home visits as well. So leave that one with us, but we're not currently in the London area. But please feel free to drop us a message if you would.
So, Chantal, I'm so sorry. We haven't had a chance to meet to update you what I was doing in London. May I just say for everybody who's in the London area, so I'm just setting up something in the Finchley Road in London, which is a CQC registered venue. There's one of the doctors there. She's a dermatologist. She wants to do other aesthetic stuff as well. So obviously in that area, we're trying to provide some IV. As Natalie said, as Chantal said, it's not just about patients just coming for the IV. They can come and have other stuff done in the same place if they want to have like a day, or a half day out. So we're trying to provide that. So I've just sent an email. Can somebody please let me know I may take this opportunity also to suggest that people think it's a lot expensive in London, but actually it's not. We can provide in a much more economical way. All right. So so we've got a venue. We're just trying to set up the last few bits. So if people can start emailing me in that email address that I've sent you from the Gmail, and so I can have an idea of how many patients we will have in the London area and which area do we need to hit. So please feel free. So I think things are looking good for London. There's a private company, two private companies who does it, but they're extortionately expensive. So we're trying to make it a bit more economical so people can come repeatedly. And it's run by the doctors. So it's not run by any company. So it's going to be run by doctors and people who works in healthcare and who has who has other interests too. So please, I just want to have an idea of the database. That's primarily I wanted to sort of tell everyone as well. So London, Bristol, Scotland was I'm surprised. I'm quite keen on Scotland now because obviously I've got a few colleagues there. Yeah, I don't personally know whether there's anything in Scotland, but I've got a doctor who's interested, not in POTS, but he's other specialty, but he's happy to provide this service. So can someone please email me as whichever city you're calling from today, so that I have got an idea on a database at what to do. And I'm actively working with some paramedics to provide this. And I'm saying it. I know many years I've done the walk, but I want to, talk the talk, but I want to really do it this time. So please, and then
Dr. Hussain, that's amazing. So I was about to mention it, what you'd put in the chat. So is it the IV saline pots@gmail.com? Is that where you want people to email you?
Have an idea who wants to get what and which cities they're from. So if you can do that, and if you can just send me the list, at least I can keep a database of all the patients. I think Chantal is doing a great job in this side, so I don't think I'll have chance. But we can do we can do in other areas, and then if you want to share expertise, we will do. So it's not unheard of. But
are you based in London then, Dr. Hussain?
I'm based in Yorkshire, but it's not that. But I go to London I do lots of work in London.
Okay.
And I also actually, while we're on this topic, there's a load of I'm sure that we never looked into it. There are loads of patients must be in the ethnic minority community that in around the London area who also suffers from POTS. That's totally undervalued. So one of the girls approached me in London about this, and so I invited Dr. Gupta to speak to one of my television show that I do, which is like a health show, and it's a terrestrial channel, and one of the thing I probably would like to interview you at some point, Natalie, about your services. It's in different languages, but doesn't matter. We can translate in English too. Because that will open up the barrier that we have, because as you know, I know they feel like they don't have any voice, especially places like Whitechapel and Ilford and Bethnal Green and Finchley Road, those sort of areas areas, they're just very undervalued, these sort of conditions, because it's very unheard of. So I think it'll be quite good areas to work on and get more ethnic minority community to be involved in such discussion, because we see very predominantly white populations, but that's not true. We do have a lot of patients, I'm sure. No one has done that work. I don't know on top of my head how many patients we have. I know you might have a better idea from across the city, but across the UK, but London do have some patients who feel they don't have any voice. So I think we can hit that at the same time.
That's great. Another fab point. Thank you very much. Right, so I just want to spend just a little bit longer on IV saline, because we do have other questions coming through. So just going back to, thank you, Dr. Hussain, that's fabulous. And we've put that email out there for you. And yeah, so just going back to Chantel. So can you tell us, people have asked, what's the name of your company? And they're asking about other areas as well. So they're asking about Nottingham. Is there anything available in the Nottingham area?
So let's have a look. So we are called Thomas Medical Services, which you will see on our little speaker thing down here or wherever it is. So we do host the occasional pop-up clinic. We have one in Glasgow, we have one in Newcastle, and we have one in Leeds. Now this is, and I want to make this very clear, it is completely dependent on how many patients we have booked in, unfortunately, at this moment in time. And that is due to the fact that obviously we are based in Blackpool, so we have to travel. However, please leave it with us. We are slowly but surely expanding. And as you will know, that if you were in the last IV saline discussion, if I say something, I mean it, because we now have that clinic in Beverley. Thank you so much again to Dr. Dinesh for that. And Dr. Clayton, whose clinic it is. But yeah, overall, we are trying to spread our services. Obviously, I am the sole kind of operational manager, if you will, so there's only so much that I can do, so please leave it with us. However, for Dr. Hussain to spread also kind of down south and everything else, it would be amazing for me. Again, it's not about getting everybody's business, it's about you being able to get the POTS treatment at a good price, at an affordable price. Which leads me on actually to announce, somebody asked about the pricing and stated that it was £65 per litre on our website. So that is £58.50 if you are a patient of Dr. Gupta's. However, we have now decreased that to £58.50 regardless of whether you are with Dr. Gupta or not. Alongside that, we have also discussed with Dr. Gupta a few days ago about being able to decrease our prices. Now, obviously, Jaya is our prescriber. So now we've been able to decrease our prices. So the first litre would still cost you £58.50. However, you can probably all agree in the chat that most of you require 2 litres or more, which therefore we've then decreased it to £40 for your second litre. Now, once we continue seeing more of you and everything else, our aim is to decrease our prices even further, be it that we're able to. And like Jaya said, the market can change. So sometimes we pay X amount for IV saline and sometimes it can increase. So we also have to take that in mind. However, we are trying, we really are. And, you know, we've got that clinic in Beverley now. So if you're around on the area on a Saturday or a Sunday, just pop in and our lovely Mags will be there and she'll have a good chat with you. She'll probably chat your ear off, to be fair. So
Okay,
make sure
I've just had another one. Is there any clinics in Ireland?
Currently not through us, no, but there may be alternatives out there. So we are just UK based currently.
Yeah. So that email again, Dr. Hussain's email is ivsalinepots@gmail.com. Somebody was asking me again that. We could come to Leeds. Excellent, Lisa. Newcastle info would be fantastic. Helen, yeah. So you can contact Chantel. How are the best to contact you?
If you type in Thomas Medical Services on Google, you'll find all of our contact details on the Contact Us page. And just whilst I'm speaking, I sort of thinking maybe on the phone, but Dr. Hussain, if you could potentially copy me in that email that everybody is emailing to you, we can maybe come together and see whether I already have clinics in that area. Because I think he's on the phone. Never mind. He's on the phone.
Okay. Right. So
I think he's on call. And Natalie, I think, can I just mention one more question? I think Samantha asked if IV saline can be given to under 18s. And then there was a second question, I guess it's to Dr. Gupta and also Chantal, is apparently an IV, apparently a POTS nurse somewhere in Midlands said IV saline is not safe, risk of infections and whatnot. So I think just to bring awareness, sorry, Natalie, I'm playing a bit
that's
of your
good.
role because I made some points scribbling down to make sure we address all our audience. So I'll leave that. So to kind of break that myth around that, please. Thank you.
Thanks, Jaya. Dr. Gupta, Dr. Kumar's just joining us. There's one here that says, I haven't tried IV saline yet, but Dr. Gupta recommended it to me. It turns out to be highly transformative. So this is from Pollyanna. Is there anything to stop you getting a port fitted and doing it at home?
Okay, so there's a few things to say. The first thing to say is you have to take benefit versus risk and decide that in each individual patient. Now, Ellie, for example, she has found something that basic like intravenous saline to make a huge difference, as has Bethany, your daughter. If we keep saying, oh, there's this risk, we're never going to get anywhere. The minute you go into A&E with a bit of diarrhea, the first thing they give you is intravenous saline. So, what we're not saying is, oh, every patient should have intravenous saline. What we're saying is we need to create facilities. We need to have options available for people to tap into if they need to. People are educated on risk. People are educated. You make decisions as to what the right time is to cross a road. When you are the person who is suffering and there is something, and by no means would anyone turn around and say, oh, IV saline is like giving someone chemotherapy. It isn't. It is a very, very basic thing. Sure, there's a risk of infections, but it's not like every single person gets an infection. Chantal will tell you what the risk of infections is. It'll probably be like 1 in 100 or something like that, or even less. And those are very minor infections. So this is not a thing that comes along with major danger. Also, the people who talk about this kind of thing aren't the people who are experiencing the affectation from the condition, how their quality of lives are affected, and also the benefits. So again, it is important that people go and sample it out themselves and then decide whether it's worth it or not. At the end of the day, it doesn't even come with just the risk of an infection. It comes with a cost as well. Yet people are prepared to pay that cost. You make a decision, don't you? You say, okay, it's worth it or it's not worth it. And if it's worth it, then I'm going to go back again. And if it's not worth it, but what we are doing is we're creating facilities and we're empowering people rather than having this kind of blanket, someone who doesn't know the patient, doesn't know their lives, doesn't know anything. But, oh, yeah, no, you don't want to do that. That's dangerous. That is ridiculous. There will be no movement. There will be no growth. There will be nothing if we continue approaching this, particularly when it comes from people who don't even believe in the condition. The second thing I would say is you have to go down this line very carefully because, again, the reason I can feel confident about advocating intravenous saline is because A, I know how bad people's lives are. B, I know how relatively risk-free this condition is. I don't want to try and recommend things which carry a greater risk. Now, when you're talking about central ports, etc., this requires a procedure. It's in a bigger vein. It's indwelling, much higher risk of infections, much higher risk of blood clots. So people like me cannot go and recommend those. One, because there is a danger associated with it, which is higher than a peripheral intravenous saline. Secondly, those are exactly the times when someone else will come and say, oh, this guy is doing something completely dangerous, and therefore he needs to be shut down. And then suddenly all these other patients who are reliant on someone like myself to help them are deprived of that. So those are things that we have to gain confidence in, but at the moment, I would recommend peripheral saline. In terms of whether younger than 18-year-olds can have it or not. I've always gone by body weight, body size, rather than necessarily age. You know, I think these kind of cutoffs where, oh, he's 17 years and 11 months, but he's got his GCSE tomorrow and he can't think. And we're not going to give him intravenous saline when it could help him get through his GCSEs because he's 17 years and 11 months. That doesn't make sense to me. The fact that he plays rugby for England is enough to tell me that he'll be able to cope. So we have to be less rigid as well. But again, everyone has their own regulations, and Chantel will have her own. But personally, none of this stops me very much. I look at the patient, I look at their build, I look at their size, and then I decide.
Okay, thank you. There is Selena is very frustrated because she's got a care plan with her NHS cardiologist to get the IV fluids when she needs them, and yet when she goes to the A&E, they still refuse and make them wait. Finding it very frustrating, even when the doctor sometimes goes with them. So we have discussed this, haven't we? And your idea was that everybody should get IV saline. Well, not everybody, but most people when they arrive while they're waiting. Do you want to explain that concept that you had? And
yeah, I mean, I think the first thing is, you know, it's very difficult because again, patients with dysautonomias, POTS, etc., because they look okay, you know, they look young, they're healthy, otherwise. They're viewed with great suspicion. So you go into a busy A&E department, they're treated very much like a waste of time. They're treated very much like, oh, why can't she just drink? Lazy, attention seeking, waste of space. That's how they're treated, which is an absolute disgrace. And that is why I was always of the opinion that patients should be able to go into an environment where there is no that suspicion is far removed. You go in, and that's what Chantel is talking about. You see, finding the right people. So Chantel basically is saying, look, you go in with, you know, the last thing we want to do is strip you of your dignity when you come to us for help. You go in there, you know that you are paying, so you have a right to get what you want, but you're not paying out of your skin. It's affordable. It's in an environment where people are not going to view this because you are surrounded by people who know what your life is like because they've heard exactly the same stories. So that is why something like this is so good, making affordable private providers. You know, why do we need to go to the NHS? Because if you think about it, going and sitting in an A&E for 8 hours, that in itself is more harmful to our mental being. It may also be financially a problem. You know, you're paying for parking, you're missing out of work, etc., etc. So there are costs to all this. We mustn't necessarily think, oh, going to A&E is free, going to Chantel costs this much, because going to A&E and being treated like you're a waste of space is not free. It comes at a great cost as well. Having said that, my own belief is that if you are going to A&E, one of the biggest problems is that you just have to wait in a waiting room until someone comes, and they're so regimented. They'll come and they'll triage you, and then they'll decide, and then they'll do some bloods, etc. Whereas actually, if you start delivering some treatment whilst the patient is waiting in A&E, and everything else can happen, then at least, you know, patients would be more willing to go and wait in A&E. The people are put off by the idea of going to A&E because no one even sees them for 8 hours, let alone anything else. Whereas with these patients, with the intravenous saline, what should happen, because the doctor has already written a letter, is you go to A&E, someone says, okay, you're here. You don't need to take up any space in the A&E department, in the waiting room. Here's your saline. Stay here. When the saline is done, let us know, and you can go home. I don't see why we don't have that flexibility. It would be better for A&E to do something like that because it creates more cubicles for the people who really need those cubicles.
yeah, can I just stop you there? I'm going to just invite Dr. Dinesh on because he's arrived, and he was telling us that they have a very different system last time, wasn't it, with the IV saline? Was it Dr. Dinesh who was telling us that last time? Think so. Anyway, let's put him on, and we'll come back.
I think no. I think with IV saline, I just say that I'm supportive of what Sanjay is saying. No, I don't have any new system or different ideas. But
Can you share your picture so we can see?
oh, sorry, I'm not on that. Okay,
No, you're hiding.
Okay.
Hello.
No, just coming out of the afternoon lunch.
Have you not got your makeup on, Dr. Kumar?
I'm so handsome. I don't need makeup at any
Ah,
time.
is that right?
So-
Well, thanks for joining us. We've been talking about we've talked about IV saline quite a bit actually. Was there anything else you wanted to add about medications and prescriptions in general, and how if there's anything you wanted to comment on our webinar?
No, I think the only thing we are still trying to build up a system step by step. First, we are trying to sort out the pharmacy now with Jaya and Dr. Gupta, and then possibly there is some support that if I could step in and try to figure out the prescription from my side, like maybe the Dr. Gupta for the patient, those who are stable, and I could help him and help patients to just review them quickly and then continue with their medications and things only for the patient, those who are stable. So that process will happen soon once we stabilize some of the things. In regards to the IV saline, as I say that even myself being a GP, I didn't know the condition until I met Dr. Gupta, and then only I could believe and trust. And I've seen his work, and I've come to the couple of meetings with you guys, and my whole attitude and thinking and looking and diagnosing now has completely changed. So I think it's a lack of knowledge. Not many people will know. Not many people know how to treat, how to do, how to deal, and how to talk to the patient. So lots of things and lots of things needs to be changed. So I know lots of frustration all around, including A&E, but I'm not sure how we could change the A&E setup or mindset of the whole NHS at the moment. It is going to be difficult, but as we have set up now Beverly Clinic, and Sanjay has said every word in a very wise way that yes, we need to, patient have to really realize that what do they want and when they want these kind of facilities and help. I'm glad that Beverly Clinic has been started. I'm not sure the feedback yet, but whether it's fully booked yet or it's running. But I'm full support. At the end of the day, patient knows what is the best for them, how they should be treated, and what is good for them, because there are not many medications to treat the condition completely. So they have to live with it. But how they could live and whether they could have a quality of life and whatever could be the mean for that one, whether IV saline or medications or just bit of a psychological support. So lots of work needs to be done. But yes, I mean, I don't have any new ideas, but I'm in support and we will be supporting in future, and we will be trying some more clinic and setups locally. So at the moment, like every patient has to go to York, and whether we could do something in this area or whether we could do some mobile clinics in other part of the country, those ideas could be explored in future.
Yeah, thank you, Dr. Dinesh, and lovely to see you again. I know you're very supportive. We are building our community of different doctors and suppliers and things. So this is just a starting point, but we need the feedback from the members and the community. So I'm just going to go to Karen. She's got her hand up. You've got a question or some input for us, Karen?
Hi. Can you see me?
I can.
Yes, we can. Hello.
Okay. I suppose today I'm talking as a patient, and it's to come back to. I just want to see everybody. So if I can speak there, Sanjay, I know you. I feel more comfortable if I can see your face. So it's going back to the whole system thing. That Dr. Gupta talked about, Dr. Hussain talked about. It just needs reworking. It's just, there is no system. And I get so frustrated. It took me 29 years to get this diagnosis. And it took me fighting, advocating for myself, and at times giving up or feeling like, well, what hope is there? But I am, I'm a determined person. I look at things holistically. I treat people. I work in therapy, but that's me. And I'm thinking about all these people, all these other patients that aren't like that, that feel ready to give up. They have nobody. Dr. Gupta, no, Sanjay, you're rare. You're a rare doctor. We need more people like you. But what do patients, what is the way of working like that? And it's not just, I know we've been talking a lot about the IV saline at the moment, but there are so many other medications. There are so many other off-license uses that have so many benefits that Sanjay's talked about. But where are the doctors that will actually hear and listen and hear patients out, and take them? It's like, again, you discussed, you have to prove you're deserving, that you are a competent patient, that is intelligent, that knows their symptoms are real and that are not all in their head, or that, how do we go about that? Dr. Hussain was talking about, I've never met you, by the way, providing different services. Can we have different clinics? Can we do this? Can we do it privately in our own group? And again, Sanjay says, well, is that viable? How do we do that? It's a system that needs completely reworking. It's management. Dr. Hussain, I think you said, some of your services have been reduced or cancelled. Great. Where does that leave all the patients that need it? Where do we go? What do we do? Who do we keep fighting with? It's hidden disabilities. It's things that we don't talk about. I had an operation this year and I had to go to the GP for review, or a specialist, another, it's actually menopause specialist. So all the dysautonomia symptoms are then impacted on this. And it's, wow, Karen, you look great. How is this? I'm not great. I'm absolutely shocking. I'm here to tell you. And then they don't believe you. And it's the whole thing. I'm going round in circles because I can feel myself getting a bit, what do we do? Sanjay, what do we do from your side with other doctors, consultants? How do we get other doctors trained up on basic human or patient care? I'm personally constantly battling, all on a polite level and trying to work with people. And I go with my evidence and my research to the doctors to say, this is it, this is that. So I'm talking right now on behalf of all the other patients that are listening or taking part. What can they do? And they're even here because they are connected to Sanjay or Hidden Disabilities. They've already, found you. What about all the others that are at the moment still not being heard by doctors that aren't even aware of this? I know we can bring awareness as this community grows, but it's massive.
You're absolutely right. It is.
What can we do?
Yeah, it's huge, Karen. It's absolutely. It is the system, and we all know that it's broken. And we're trying to find how until it is changed. If it changes, we are trying to find ways that we can survive, adapt. What other things that we can do either independently. Sharing the information, so when somebody says, well, I know how to get this and this is helping and that's working, and this is a starting point, getting people together. And Sanjay and myself and some of the doctors, we've talked about, because they're frustrated too. They are being restricted. They are getting their services cut, and the people here are all patient led. So the more people we get together like that, the more impact hopefully we can make. I've got a couple of people who've got their hands up, so let's just see what that. Thank you very much for that, Karen. And we'll have to have a little get together as well, won't we? and lovely to see you again. So, but really good points, and let's hope we can make some changes. I'm just going to go back to Jay, see if he's got any a response to that, and if he's got some ideas, because you've got your hand up. You have to unmute yourself.
I do, Natalie. Thank you. But I think Joanne's got her hand up before me.
Yes, she
It'll be
did
rude.
actually.
Shall
Sorry,
we
she
ask?
did.
I made all the points, so we'll reply to that. I do want to say before Dr. Gupta comes in, but let's give Joanne an opportunity first, and then we'll.
Joanne, can you? Joanne, can you?
Hello.
Hello.
Hello. Thank you for. I've just found this. I think I've missed some of it and just joined some of it also. So it is very frustrating. So I live in London, and my daughter was diagnosed with POTS a couple years ago, and I personally feel that the system is failing her big time. She's tried all different medication. Her quality of life is deteriorating. She was meant to go to university. She couldn't go to university. She just recently had a really bad flare up of POTS by changing medication. I've set up A&E with her for 8 to 10 hours at a time to be told that, oh well, she has POTS, so we can't help. We're waiting like 2 years to see her POTS specialist on the NHS. But if I went privately, you could then see him within 3 months, which isn't a problem. I'd happily take my daughter to go privately to see her. But obviously, financially, you wouldn't be able to upkeep that all the time. And I was quite interested to find out about this IV saline service, because I'm just wondering if this would be very beneficial for my daughter. Some days she just can't even get up out of bed. Alongside POTS, it's also affected her mental health. It's everything, and no matter where I go, I'm just hitting a brick wall, and that's including with my GP as well. They just can't help me whatsoever. So this is a really good group, but obviously I'm just wondering what services there are in London that I would be able to get in contact with to try and get my daughter's life back. She's only 19. She was diagnosed with it when she was 17, and for 2 years her life has stopped. And every day she may say, what's the point in going on, because I can't live like this anymore. So as a mum, that is really heartbreaking to hear. You go into work every day knowing full well that your daughter's suffering at home, but I don't know of any services in London. Obviously, yes, she's under King's College in London. She's under Dr. Gall. But again, with Dr. Gall, it's 2 years. I can't get no communication from him whatsoever. So yeah, so it is very, very frustrating, but also very heartbreaking at the same time. So yeah, it's just really what services I can look into in the London area.
Yeah, thank you for that, Joanne. And I absolutely feel your pain, because I've gone through a very similar journey with my daughter. And it is really tough.
Yeah.
It is very difficult to know what to get, and I felt like there wasn't anything available, which is why I set up the charity. We don't deal with the London area. I don't know if Dr. Hussain is still here, because he goes down to London quite a bit. I don't know, he was on call, so I don't know if he's left now. Sanjay, have you got something that you can help with? You have to just unmute yourself.
Your story is very similar to the story of a lot of patients all around the country. The first thing I'd say is that private medicine is not as expensive as it may seem initially. I have a lot of private patients. The waiting list to come and see me on the NHS is 2 years. I have no support in any way. In fact, my own colleagues think I'm mad, because they think, he deals with mad patients and therefore he must be mad. So I'm viewed with the same kind of suspicion and lack of understanding like my patients are. So that's the first thing. So whilst one would love to make more NHS services available, we feel very isolated as practitioners because we don't really get any support. And wherever it is, my colleagues are saying your waiting lists are building up because of these POTS patients that you want to see. What a waste of time. They would love to get rid of them. They would love to get rid of that, and they would rather that I prescribe cholesterol lowering tablets, etc., etc. I'm fortunate because I have a platform, I can speak, and therefore I haven't been thrown out, but I'm very much viewed with a degree of suspicion. And I'm also viewed with a degree of suspicion because a lot of patients who want to come and see me will then pay privately, and they think, okay, he's doing it for his private practice, But it is impossible not to be invested in the patient if you've spent so much time dealing with them. So what I do in the private sector, and not everyone else does it, is I see the patient for the initial consultation and I give them all the medications on day one. So I say, here are all the medications that work for POTS. When you want to go, you go and you can try this. And if this doesn't work, you can try this. And if it doesn't work, you can try this. And I give them that. And then I do their letters because I say to them that, look, the thing you need from a cardiologist, the thing you are coming to for a cardiologist is access to medications and advocacy. Those are the two things that we can do. You can get lifestyle information on any website. You can access physiotherapy from any practitioner that you want to pay for. The reasons you're coming to me are advocacy and medications. And we can do that. Advocacy doesn't cost much. It's a simple case of me doing a letter saying, this is this patient. I believe their symptoms. This is what this will mean for them. And that makes their life easier. And I give all the medications on day one. So largely private care, it will be more expensive if you go to a cardiologist who says he's interested in POTS, but isn't actually interested in POTS, who will then do, oh, you need this test, you need this test, you need this test, you need this test. But certainly in my case, virtually all my patients get all the medications on day one. And so there is no additional cost apart from their initial consultation fee, which is about £200. So what I'm trying to get across is that you can access this. It is not as expensive as it may seem. The medications were a problem because when you come to see me privately, I have to issue private prescriptions. But that is exactly where Jaya comes in. That is exactly why we approached him. And we said, how about making these medications comparable with what someone would pay on the NHS, which is exactly what he's doing.
Okay.
Thank you. Can I just go back to Jay now, because he's had his hand up for quite a while. I'm just conscious that we've been on for an hour and a half now. Jaya, thank you for that, Joanne. Jaya, what was you going to say? Yeah.
So a couple of things. Actually made some questions around the medication related queries that came through there. So I want to address them because I don't want them to feel that they've answered a question and not answered. Ronnie's left, I think. She's asked a question about weight loss injections, and because she's left, she's emailed me. I've got the email and I'm going to reply via email. I'm going to call her actually. We've dealt with NHS and POTS quite a lot. So I'm going to, that's Elaine, I think. Jade asked a question around.
Sorry, Jay, can I just interrupt? What email do you want people to message you on? If they've got questions for you afterwards about medications and prescriptions, are you happy for them to contact you?
Yes, yeah, absolutely fine. I am on More Than Just Medicine website with Dr. Gupta on that. So if you email that channel, I am getting back to all the patients that come through there, either via phone call or an email reply. So that might be the best place to come through.
When you're not chatting, if you want to put your email in the chat box, and then people will know how to contact you. Yeah.
Thank you. Thank you. Jade asked a question around metoprolol and can it be taken when required? It's a beta blocker, and I'm guessing it can be taken when required as per what the symptoms that you have, unless Dr. Gupta has got a different opinion on it. So yes, Jade, that is a possibility that you can take it when required. In fact, we do use in some of the cardiac patients beta blockers, pill in the pocket basis. So that means they for irregular heartbeat. So they take it when they get the flutter and whatnot. So yes, that's fine. Fine. Helen asked a question around midodrine and the side effects. So if you talk about side effects with medication, we can break it down into many different sort of based on its frequency, what the trials, the medicine trials and whatnot list. So common or very common, uncommon, rare or very rare, frequency unknown. So that's how it's kind of broadly divided. And for midodrine especially, some chills, flushing, gastrointestinal discomfort. Now, I'll mention GI discomfort, gastrointestinal discomfort with 99% of the medicines when you first start taking them. Okay, because imagine you're putting a medicine into your stomach, which is a chemical and your body's not used to it. So 99% of the medicines will cause a GI upset in the first week or two when you start taking these medicines. Flushing and headache, kind of related because with midodrine, you're opening the blood vessels to increase the blood flow. And flushing and headache are quite common when you first start taking it. So that's listed under common side effects. Nausea is one of the GI side effects. When you put something into your stomach, that's that stomach can't tolerate. That's one way of telling you that I don't like it, is nausea. So uncommon stuff is things like anxiety, arrhythmias, irritability, or sleep disorders. So now, if you are particularly concerned about it with any particular side effect, I do have Dr. Gupta's patients ring me about side effects on our pharmacy telephone number or email me. I do speak to them from time to time, explaining how to go about with these side effects, how to manage them. No medicine is side effect free. But how to manage these side effects along with treating the condition, that's where the risk benefit ratio comes in. And that's where I'm best available to advise as to how, how great the risks are when you describe me a side effect, and then I'll tell you, well, actually, I think you need to stop this, and then get back to Dr. Gupta to see if any further consultation is needed, etc. So that's what Helen's question. Cleo or Leo, LND and private, we are going to publish the prices for the LDN on the private basis. So bear with me on that. Christina asked alternative to fluorocortisone. I think that's something for Dr. Gupta to answer around. She could not tolerate fluorocortisone when she first took it. I didn't know what that intolerance is. I would like to explore a bit more around it. Please feel free to email me, Christina. Sometimes intolerant means whether it's a side effect or actually is a side effect that we can manage, or you're completely not able to take it at all. It's a one of its kind medicine, fluorocortisone. So I don't know, Dr. Gupta, have you got any answers for fluorocortisone alternatives?
Yeah, thank you. So in terms of, obviously, fluorocortisone works by you cause more volume retention in the body. So there are 3 or 4 other things you could use instead. Number 1, just salt. Lots of salt causes volume retention. Number 2, midodrine is actually compressing the body, making it smaller. So the amount of volume is increased because the body's become a little bit smaller. Desmopressin is a hormone, as a nasal spray. It causes, I think, and Karen is here. Karen's had experience with desmopressin, and it does help. And then the intravenous saline is obviously the other thing. Those are the 4 things. Whilst I've got this, I just wanted to share a few other things. I mean, Karen's point was that, how do we change? How do we fix the system? And the answer is that we are doing that. You see, this is not just about raising awareness. We now have an IV saline clinic hardly anywhere. This could easily take 10 years to do on the NHS if you ever wanted to. We now have medications which are much more accessible. A few other things you should be aware of today. We're very fortunate. Sammy Allen has joined. So the phone number that you can see, Sammy's on her phone. There she is. Sammy.
Hi.
Yeah, Sammy.
Hello.
Hi, Sammy. And the really interesting thing, the really good bit of what I do is I get to meet some really wonderful people who are trying to make a difference in their own from their own side. And Sammy has a unique insight into advocacy for students with POTS. Now, this is a much needed service where students who develop this condition are unable to keep up with their curriculum requirements, are treated with disdain by their teachers, etc. The school can be inflexible. They don't know how they're going to navigate their careers. And here is someone in Sammy Allen who is offering an advocacy service and sitting on panels and making it easier for the students. So that is something else that makes a difference. It's not all about medications. It's about that. A couple of other things to say. We now are working with a physiotherapist, Emily Cochran, who has POTS herself, who has agreed to talk to all patients with POTS free of charge. So half an hour, so 10, 15, 20 minutes, you can contact Emily Cochran, and she will talk you through POTS, living with POTS, exercises for POTS, etc. We have a dietitian now, Chloe Hall, who is also accessible for POTS. So we are trying to create a network of people who are not motivated by money, but more so motivated by the desire to form a community and become valuable members of the community. One other thing I'd like to say is that we take on lots and lots of private patients for free. So, I think one of the Joanne was saying, look, we can't afford it. It's okay. I have a lot of NHS patients who are now faced with the possibility that the NHS services are closed and they can't afford private care. And I've taken many of them on for free at no cost to them at all. So we are all invested in this condition. We want to make a difference. It is not all about money. And certainly the people that I'm working with here all seem to be more than willing to cut down their profits to make a difference.
Thank you, Sanjay. That's great. And some people there who I need to obviously connect with and get their information shared afterwards, and maybe do some other webinars with them too. So just going back to Jaya, remember to put your details in the chat box for everybody.
Dr. Gupta's already put the
he's done it. Well
website on.
done. Teamwork.
Yes, thank you.
And there was a few questions you was trying to answer, I believe.
I think I've covered most of it.
Have you? Can I ask you one? Right, a lot of people are asking about electrolytes. Is that something is there a way of getting those cheaper?
Sanjay, do you want to add?
Again, absolutely. So the advantage of having lots of people is that you can go and negotiate with providers, right? So because we are, again, fortunate, we have a community of patients. I was able to go to Vidrate and I was able to say, look, you need to give us discount codes because we will direct these patients to you, but you've got to make it cheaper for the patient. So we're able to do all that. We want to approach insurers and get them to reduce their prices for POTS patients. But this all happens when a community comes together. So again, what I would also like to very much encourage is, now that Chantel has done such a brave thing, she's set up a clinic, it would be great if the POTS community supports that. It would be great to see that her clinics are booked so that this thing that we've worked hard to set up doesn't just get dismantled because you think, okay, well, no one's coming, so is there really any point in for her? So what I'm trying to do is bring the community together and say that actually we all need to support each other to make these services run. And once these services start running, people will see that there is merit in replicating that in different areas of the country. And that is how we start making a difference. We are no longer reliant on ignorant people treating us, but actually being able to go out there and find the right people for us. So that's what I would say. I think there is no doubt that we can, and I'm very happy to go and negotiate lower rates for absolutely everything, in the hope that people can access them and use them.
Yeah, absolutely. And we will share the, any discount codes we can get together, or if anybody in the community who's here today has got things that they've come across that help, don't forget you can contact hiddendisabilities.org.uk as well. We want to get more information on our website. Dr. Gupta's got lots of contacts. We'll put them on our website as well. We're building our YouTube channel, and obviously Dr. Gupta has lots and lots of videos on his channel as well. And we'll get this out there here. We'll get this out as well. Other comments coming through about different advice, how many electrolyte sachets you can use a day. I use Vidrate and average about 6.
Young people, you've got healthy kidneys, so you take what makes you feel better. Your kidneys will do the rest. That's what I say. If you want a number, most of my patients take Diarylite and they take 2 sachets a day. But again, your body will tell you, and there's no one better to understand your body than yourself. So what I want to try and avoid is for people to say, oh my God, if I take this, my blood pressure will go too high. My doctor says, oh, I'll have a stroke. That doesn't happen. You're young, healthy people most of the times. If you've got no other major abnormalities with your organ systems, then it should be fine, I think.
Yeah, somebody's asked about are there any nicer ones than Vidrate? Well, my daughter's been taking Diarylite. Yeah.
Diarylite, yeah.
And she said that's much nicer. Susan's got her hand up. Let's go back to Susan.
Hiya, Natalie. Just you can get something called Fizz, which are really nice, and Ellie uses the electrolytes all the time. Absolutely brilliant. They are nice. I've tried them. And also magnesium. Chantel also does magnesium injections and B12 and all sorts. And Ellie had a magnesium injection in a saline the other week, and it was amazing. So she offers a lot more than just the saline. And Dr. Gupta likes magnesium.
Okay, we haven't discussed magnesium yet. Thank you, Susan. Did you want to comment on that, Chantel?
Yes, so we do. We offer magnesium, which you can have intravenously alongside your IV saline. Obviously, magnesium, we would need to do a more in-depth consultation, most likely through Jaya as well, in terms of the prescription, because we've changed slightly the way that we work our prescription system with Jaya. So leave that one with me, but that is an optional add-on that you can add on. So yeah, that's that. And just quickly, whilst I'm speaking, I wanted to bring back some awareness in terms of, we were briefly discussing some infections and that kind of thing that Dr. Gupta kindly explained and everything. But I wanted to go into detail about checking the clinic that you're going to. So everyone that comes to us will completely see that we do everything sterilely. You'll see us open every package in front of you. You'll see us attach the giving sets there, and you'll see us open a fresh cannula. If you go to a clinic where none of that is happening, please leave and make it the norm to leave before you get that infection. An actual infection through cannulation of, especially of the AF region, is very, very, very unlikely, extremely unlikely if your clinicians use the right technique. So just be careful with where you're going. And if at any point, we're always going to answer the phone. So if at any point you're unsure about what's happened to you, you don't understand the procedure, and your clinician hasn't explained that to you, then please just give us a ring and we'll be happy to explain.
Okay, can you also explain about how many number of attempts can be made?
Yes, so legally there is only allowed to be 3 attempts per clinician. That is a legal requirement. So wherever you're going, they should not be attempted any more than 3 times per clinician. There is some aspects where, such as Ellie, for example, it was me and Harrison on a first visit. I think it was Harrison's second attempt where he ended up gaining access into her bicep, into her shoulder here, which isn't the most comfortable, but obviously for Ellie, we gained the access, so we were just like, that's fine, we'll stick with it. But 3 times per clinician is all it should be.
Yeah, and unfortunately my daughter went somewhere and they had 10 attempts in her hand and she was massively bruised. And why is it only a limited amount of attempts, Chantal?
You are at risk of hitting a nerve, creating something called a hematoma. So a hematoma is essentially, if you can envision that is your vein in your arm, it's essentially the needle going through and through the vein, so piercing either side and essentially bleeding under the skin, which causes a hematoma. It can happen. It actually happened to Ellie the last time she was in the clinic. It is completely normal for that to happen. Just apply loads of pressure and ice if it is to happen. However, if you go anywhere and you have more than one attempt and they go to use their same cannula twice, please run full speed out of the front door, because these are the things that cause the infections. Reusage of any sort of needle is completely strictly illegal and should never happen. There was actually a girl who has gone quite viral on social media who now has full paralysis in her arm for thinking, oh, I don't think that they should be using that needle twice, but they did, and she ended up with an infection. So it's all about you guys as well as the patients doing your own research and just determining wherever you're going, whatever clinic that be, including ourselves, even though we are, ensuring that everything that they are doing is completely correct. And if you feel uncomfortable, to speak up.
Thank you.
Chantal, you're still loved by Ellie, don't worry.
Yes. Okay, thank you very much. I just want to go, we're going to be running out of time, want to finish at 3. So I just want to go to Alicia if she's still on, because she has a question for us. Are you still there, Alicia? We've been a while, so she might have had to go. Here she is. If you can unmute yourself. So I'm going to ask it for her in case she's there, but she's struggling to unmute, I think. So Alicia's pregnant. Congratulations, Alicia, first child. However, are you there, Alicia?
Yeah, sorry, I've had to get away from the building where.
Fabulous. Okay. So did you want to share your screen? You don't have to.
I'll leave it off just because I'm like in the middle of like nowhere.
No problem. But yeah, you're pregnant. Congratulations. You've got POTS and other things, and you had some questions because it's more complicated for you.
Yeah, so I've got epilepsy and POTS, which is quite a new diagnosis, is my POTS. But it's still sort of up in the air. But I struggle to regulate my body temperature anyway, but since getting pregnant, it's definitely got a lot worse. I was wondering if the saline would be helpful for me, or if I can still have that whilst pregnant.
And also you've been taken off most of your medication, or all of it, haven't you?
Yeah, I'm not taking anything, yeah.
And you're actually due to give birth in the height of summer.
In July, just to add to it all.
So Sanjay, how can you help? You need to unmute.
So obviously, I think some of the medications are definitely known to be harmful in pregnancy, such as ivabradine, and that's why they're not recommended. Some of the medications don't have enough evidence for us to know either way, and we prefer to not use them if possible. A lot of patients worry about pregnancy, and certainly in the first trimester they get worse, but in the second and third trimester they get better. And the reason they get better is because they're expanding their plasma volume naturally with the pregnancy, and so they're more hydrated in general. So whilst it may seem that as you progress in pregnancy, you'll get worse, my experience has been that most patients get better with pregnancy. Of course, it becomes harder after they've delivered, but by that time they're so occupied looking after a little one, etc., that they sort of manage. If you wanted medications in pregnancy, then the medication that you can use are beta blockers. But again, if you can go through the pregnancy without any medications, it's even better. With regards to intravenous saline, I don't know. I mean, I think Chantel will be able to tell you what the regulations are around that, because she's an independent, obviously, provider. I certainly, unless the patient were in hospital or so unwell that they were in hospital, they couldn't get out of bed, I don't generally recommend it. That, again, because I'm a little bit more cautious because we're offering something which is sort of outside the evidence base, and therefore you don't want anything to go wrong. You don't want people to raise questions, because when they do, then the whole service can just stop, and so many other patients end up suffering as a consequence. But Chantel will probably be able to tell you better.
Chantel?
Hello. So we actually do IV saline for POTS for one pregnant lady at the moment. However, we only do 500 milliliters. I know I said 500 liters then. And we monitor her sodium and potassium levels throughout as well. It's really important that you go somewhere who feels comfortable looking after you. Is it Alicia? Am I pronouncing that right? So ensure that you're going somewhere who knows what they're doing, who knows what to do in case of an emergency, and also double check that you are on a prescription as well. Because if anything was to go wrong, you need to ensure that you're under a prescription and that you have the safety net around you. It's also important to read thoroughly through the what's the word I'm looking for? Like consent form that you sign if you're happy to go ahead. But I'm very lucky in terms of the position that I'm in, because I've got Dr. Gupta, I've got Jaya, I've got Dr. Dinesh, I've got everybody who I can always reach out to in case of me feeling uncertain about anything. But for myself, as the owner of the clinic, I would not admit any more than 500 milliliters during pregnancy.
Right, okay. Thank you.
What about electrolytes? Are they still okay to take?
I believe so. Again, you just wouldn't want to overdo it, because like how Dr. Gupta explained in terms of the kidneys and stuff, overdoing your sodium and potassium levels can have negative impact on your kidneys. And obviously during pregnancy as well, you're at a higher risk of that anywho's. So yeah, just be careful. Make sure that you get it. If you are taking IV saline or electrolytes on a regular basis, especially when pregnant, just ensure that you're checking your sodium and potassium levels quite regularly, and you should be fine. And like how Dr. Gupta said as well, you know your own body. If something feels wrong, make sure to reach out.
Do you help people check? Can you check those levels when they come to your clinic?
We do, yes. So we do blood testing as well, where results will be back within 24 hours.
Okay, super. Does that help, Alicia?
It does, yeah, thank you.
Oh, you're welcome. Have you got anything else you want to ask?
No, I don't actually.
Okay, well, thank
Thanks
you
a lot.
very much
Thank
for
you.
turning up. Okay, so is there anybody else who has got a question they don't feel like has been answered? I know you've got connections now with Thomas Medical Services and Chantel there, so you can message her direct or call them. You've also got connections with Jaya, the pharmacist as well, and you've got the charity hiddendisabilities.org.uk, or you can email me, natalie@hiddendisabilities.org.uk. So I don't know if anybody else, if you want to put your hand up if you've got anything urgent that you would still like to ask, or if any of the doctors or specialists here would like to, anything you feel like you haven't covered yet. Well, that's a good sign. Go on, Dr. Gupta.
I think from my side, what I'd like to say is I think that those patients, particularly like Joanne, if you're struggling to get the help and you can't afford it, please send me an email. I'm sure we can take you on free of charge. That's not an issue. That's the first thing. The second thing is we have set up this website called mtjm.co.uk, www.mtjm.co.uk, where you can access Emily Cochrane, the physiotherapist. Send her a message. She'll happily ring you, talk to you free of charge. There is a dietitian there. So we're trying to create a place where you can just go onto one website. You can get access Chantel there. You can access Jaya there for any pharmaceutical related advice. You can access Chloe Hall for her POTS. You can access Dr. Dinesh Kumar for general practice advice. You can access Emily Cochrane. So So we want to create facilities. We want to create facilities, hopefully, for anyone, not for people in Yorkshire, not for people in England, but for people around the world. You can do all that. Obviously, all these things do cost some money, so there is often a small cost associated with it, but our motivation is to make a difference. Our motivation is not profit generation. That is really important, that I want to get across, that we come from, I certainly, and the people I've worked with come from a place of authenticity. When we were trying, one of the biggest hurdles we had in terms of setting up an IV saline clinic is simply finding a premises which is affordable. How do you find a premises which is affordable? Who's going to pay for that premises? For something, that no one else seems to believe in. And then that Dr. Kumar came in, and suddenly we have a premises. This is through the charity and genuine care that people like these show this community, that they're making things available. If we do it, and we do it more often, I'm sure we can set up a service here which will want to be replicated by which people will want to replicate in other areas. And that's how you make a difference, I think.
Yeah, thank you. And I totally agree. So I'm going to, Louise has put her hand up, but we'll have to be really quick, Louise. We've only got a couple of minutes left.
Nice. Sorry about that. I did put my question in the chat right at the beginning, and I think it's obviously got lost, but I think I'm quite lucky that I already have an NHS cardiologist, because I was diagnosed with POTS just a couple of weeks ago following sepsis. I was actually really quite ill in hospital with sepsis, and apparently it's quite common to get POTS after sepsis. He's considering putting me on ivabradine, and I'm obviously quite new to this. My pulse can be 160 when I'm stood up, but it can be 80 when I'm sat down. And so my concern is, does it bring down your whole rate? And in which case, what's my resting heart rate going to be? Because clearly my only issue is when I stand up and try and do things, that's when it's an issue. It's not when I'm resting.
So I can answer this. What you're describing is a concern shared by virtually every POTS patient. Every patient who comes to me will say, my heart rate goes fast when I'm upright, but then there are other times when it goes slow. And certainly at night, it can go down to 60, or it has never dissuaded me from giving them my ivabradine. That's the first thing. I don't think the ivabradine will push your heart rate to such slow levels that something bad will happen to you. The second thing is that the half-life is smaller. So I say, well, take it when you're likely to be upright. Take it first thing in the morning and take it at lunchtime. By the time evening comes, it goes away. So, and the other thing is, the third thing is, you will know if it's working for you or not. Go by your quality of life. Is my quality of life better? Don't measure too much, because that will just scare you, If your quality of life is fine, if you're more functional, it doesn't really matter. Just go ahead and take the medications and become more functional. That's the most important thing.
Okay, thank you so much, Sanjay.
Thank you.
Thank you.
Can I quickly make a point? Yeah.
Yes.
Yeah, I'll speak to Sanjay anyway later on, but I think what I will suggest that we have the PCNs nowadays. What is PCN? It's like a group of medical surgeries or the GP surgeries. And we also do have our PTL days, protective time learning. And these are the very good meetings where we call different consultants, or we discuss whatever we need to in the benefit of the PCN or patients or the doctors. So I was just wondering whether we could have Sanjay on, and whether he could promote POTS kind of educational half an hour presentation during these PTLs, and he can approach different PCNs and say that I'm happy to put a half an hour presentation. Because what I realized, unless I didn't know about the POTS through Sanjay, I didn't know much. I just heard and I just read 2 lines, and that's it. That was my understanding of POTS. But since I've been in touch with him and I've seen patients and I've sat with him in a couple of clinics at York, my whole attitude had changed, and I'm really kind of want to do something. So that may be with many GPs like myself. So that's something I can do that in my area, of course, in around Burlington, York, Scarborough, and Hull area. But then if you can approach the York side as well, I mean, it could be like maybe a few presentations in a year time, and if that happens, I'm sure that will make a big difference to the GPs and to the patients.
Yeah, I think that's a really great idea. And it's not just POTS, there's other hidden disabilities as well that a lot of GPs, I mean, you're all great, you're all patient-led, but a lot of our members and a lot of the community are struggling with their doctors in their area who are not understanding and being quite dismissive, and they're getting gaslit and things like that. We've experienced it ourselves. And I do think I do think it's important that we give our members and the community a voice. And if we could get the end users, the people with the lived experience in front of these doctors as well, so that they can hear actually the lived experience, what people are going through, and get them to understand and be a bit more empathetic. Jaya, you've got your hand up.
So one last thing I wanted to add around how to get the commissioners listening, and this is a battle that I fought on a separate note, and I'm sure Sanjay has done similar battles with these commissioners and things. So if you think about a common condition, which is obesity, and we spoke a lot about it during COVID time, it's a precursor to a lot of chronic conditions such as diabetes, heart, cardiovascular disease, which is quite a lot of a health burden to the NHS. However, even having miracle medicines now at the moment, things like Manjaro, Wegovy, NHS is struggling to fund these for patients, knowing that if we can treat obesity, we can treat or prevent a lot of conditions for the future. However, the way NHS works is, I think, the budgets are set year on year with the local commissioners, and they only think for that particular year. They don't think beyond that year. And I've lived through this experience when I was trying to prove a point with chronic kidney disease and implementing some of new treatments within the NHS locally. And they came very hard on me on prescribing certain drugs that were preventing renal decline. However, when I showed a budget impact analysis for the next 5 years, they seemed very least interested. Because in the 5th year, there's a return on investment that I showed to the NHS on reducing the hospital admissions. But unfortunately, we're in a system where the commissioners only think 1 year ahead. Their budgets are set for only a year ahead. Whereas when we are trying to think a lifetime of trying to manage a patient and their conditions, obviously preventing is far better, but not in case of POTS, but other conditions. They would not want to listen because they're not concerned, because neither the politicians are interested, because think about it, the NHS is a politically driven system. And it's a sort of a tool that every politician uses in their manifesto and agenda to say we're going to change this in the NHS and that in the NHS. However, it should be independent, I feel, and let clinicians deal with it rather than the politicians dictate the budgets on it. So I don't want to go much detail in it, but there we go. That's where what I would say is we'll continue to fight for people we believe, I think, deserve the right treatment. However, there is, I'll tell you that there is at most, no from every single commissioner that we could meet and ask and say and explain. So the patients have got a better voice than the clinicians. So write to your MP, write to your local PCN boards if you are in particular PCN, etc., and see what they say.
Yeah, thank you, Jaya.
Thank you.
And Jaya's going to be at our welcome event on Wednesday as well, so you can speak to him direct as well as contact him on his email as well. So it's go on, Sanjay. Make it quick.
Natalie,
We have to wrap up.
Yeah, could I just say also that, when you talk about hidden disabilities, the problem with something like this particular thing is it's known by different names by different specialties. Okay, so you go to a metabolic person, they'll say it's chronic fatigue syndrome. You go to a neurologist, they'll call it functional neurological disorder. You go to a cardiologist, they'll call it POTS. Someone else will call it inappropriate sinus tachycardia. Someone will call it fibromyalgia. Increasingly, we're beginning to see it being called ADHD, all this kind of thing. So what I'm trying to get across is that when you look, we are probably still dealing with only the tip of the iceberg in terms of people who have a name for this condition. All the long COVID, a huge number of long COVID patients probably have the same condition, a post-viral dysautonomia. So one of the things that could be helpful is for all those people who are listening here to remember that these people are running their own, someone will come to you and say, I've got FND. Bear in mind, it may be the same condition. And unfortunately, because it's known by a different condition, it'll be managed in a different way. So the FND people say, oh, FND just needs to be treated like this. If they don't recognize that that could just be one face of POTS, they won't get the treatment. Similarly with long COVID, unless a magical treatment comes out for long COVID, these people are just contacted once every 6 months. Oh, drink more, pace more. But if you start seeing it as POTS, then these people can get some treatment and can get better. So that's important in terms of empowering people to go and start questioning, could it be this? You have this, and you have this, and you have this, which is all the kind of things that other POTS patients have. So why isn't it POTS? And the second thing to say is a lot of this is inherited as well. So you see children, and then when you look further, you'll see their mothers have it, their siblings have it. And I find it incredible when people come to me and say, 10 members of my family have POTS, and now my daughter's getting the same symptoms and they think she's mad. Why? Well, how have we become so ignorant to what is so obvious that if you've got so many family members with exactly the same thing who are complaining of the same symptoms, then why is this poor child going to see a psychiatrist instead of someone keeping their mind open and saying, oh, you could have exactly the same thing as your family members?
Thank you, Sanjay. And can I just say from the charities perspective as well, because we have a diverse mixture of members, all with different hidden disabilities. I mean, lots of them do have POTS, but we have MS and all sorts of other things, and a lot of neurodivergent members. There is a big crossover, and a lot of them, if mum's got POTS, the likelihood of one of the children having autism or being neurodivergent or having other issues, there might be sensory issues, it's so common within our group that I have noticed it personally, and I've thought, oh my gosh, there is a huge crossover here. There's got to be some sort of link here with these conditions. And other things where I see a link as well is a lot of them are very empathetic. They're very caring, giving, kind-natured people. And there is quite a bit of trauma that has happened in the group as well. So there are a few things where I'm thinking, I mean, I am not medically trained at all, but I can see, and that's one of the benefits of dealing with our community is it is not just one condition, it is a mixture of conditions, and most of them have more than one. Even the POTS patients, they'll say, well, I've got AIDS, I've got, and a lot of them actually, Dr. Gupta, I don't know if this is a thing, but a lot of them seem to be autistic or neurodivergent. So I think we're just going to build, the more we talk, the more we share and pool our resources and work together, the more impact we will make. So we are on a journey. Charities are only just starting its second year. So thank you so much for everybody for joining. We still have 57 participants. I know you can watch this afterwards as well. It's been recorded. It'll go on the website. Dr. Gupta's going to share it, and Jaya's going to share it, and probably Chantal as well. So thank you so much for coming. We will do another one next month, and we're building our panel. We've got lots of things coming your way, and yes, thank you so much for coming, and enjoy your weekend. And we hope it's been helpful for you. Thank you from us all. And bye for now.